tomorrow. So our next speaker is going to be Dr. Olga Toleva. Dr. Toleva actually received her medical education in Bulgaria, in southern Bulgaria, and then she came to UBC where she did family medicine and then internal medicine. She then went on to do her training in cardiovascular medicine and interventional cardiology in Edmonton, and then came to Boston and spent time at the Harvard School of Public Health where she received an MPH. She is currently in Manitoba. She's been there since 2014. She has strong interest in the area of interventions with both TAVR as well as interventions with SCAD. She also has interest in coronary physiology, is very active in the cath lab there in women's heart issues, and she's on the Canadian Women's Heart Health Alliance Advocacy Group. And she's going to talk to us about the hospital presentation of SCAD patients with those really complicated things like non-STEMI, STEMI, VTVF, cardiogenic shock.
Thank you. Thank you. Good afternoon. I hope you're still awake. And I'll keep it brief because I know there's lots of good discussion that is coming afterwards. The topic that Jackie gave me today is to run through the common presentations of patients who present with spontaneous coronary artery dissection. So there are several clinical components that we're going to go over, and I'll try to keep it simple because I know there's a lot of patients in the room, and sometimes we tend to get too technical and explaining things and looking into the details. The G's are over my head. I can't even follow some of these pathways, but we'll try to keep it so everyone gets some of the messages of the talk. As you know, SCAD is usually acute presentation. This is how we make the diagnosis when someone comes into the hospital with acute chest pain, and often they receive a diagnosis of acute coronary syndrome, whether it's non-STEMI, STEMI, and there are more dramatic presentations like sudden cardiac death or a cardiogenic shock. We know that the classical heart attack usually presents with atherosclerotic buildup and eventually a plaque that erupts and activates the clotting factors and occludes the artery. I used to play this video for students, and they were very excited to see how this actually works and how aspirin and Vines and all the other medications work on the actual formation of clot. Well, things are different with SCAD. We know that there is occlusion of the vessel, but there is no clot and no cholesterol buildup. And as many as you are here in the audience who are survivors, most of you don't have high cholesterols, don't have buildup in their arteries, and are quite fit and living healthy lives. So why does it happen? Why young women develop narrowing of their arteries? Why do they develop heart attack and end up sometimes in really very critical condition in the cath lab? Well, there's lots of theories, and I know we talked about the formation of the hematoma, the intradural hematoma, which compresses the lumen of the artery to a point that there is a complete occlusion of the flow to the myocardium, which causes ischemia and eventually a heart attack. In some situations, there is an actual slit in the lining of the vessel where the blood from the lumen of the vessel corresponds to the false lumen, and that way compresses and prevents the blood flow. As in acute coronary syndrome with buildup of cholesterol, we see a spectrum of presentations with SCAD. Even though there's no clot formation, there are different levels of occlusion of the blood flow, from very severe, where the patient comes in with chest pain, but there's no ECG changes and no troponin elevation, to the non-ST elevation MI, and for those of you who don't read ECGs very often, it basically is not complete occlusion of the vessel, where you have some ECG changes, for example, these T wave changes, but no true ST elevation. And these are myocardial infarctions that are not true emergency. The patients come into the cath lab and the vessel still has flow. To ST elevation and MI, this one's very subtle here, just in the lateral leads, where there is occlusion of of the vessel with lack of blood flow, and eventually significant damage to the heart muscle, to dramatic changes like this, where you have ST depressions and ST elevations, and you can see that the whole entire ECG shows very diffuse ischemia in multiple territories, which you can possibly imagine that there may be more than just one vessel blockage, but maybe a left main or something more dramatic. And to the most dramatic presentation when patients present with sudden cardiac death or ventricular fibrillation, which is a rhythm where the heart is not pumping efficiently and there is no blood flow to the brain, and the patient requires resuscitation with electric shocks. The signs of heart attack is something that we have been advocating through Heart and Stroke and Women's Heart Health Alliance, TV and radio, to make sure that women are aware of the symptoms and recognize them early and call for help. Because we know that often women may present with different symptoms. They may not be what we call typical symptoms of chest pain, but still significant to warrant attention and call to 911. So I'm just going to repeat this again, even though we all know that chest pain is the typical presentation. Often this could be shortness of breath, lightheadedness, radiation to the arms, the neck, sometimes areas that are not typically related to the heart, like back pain, neck and jaw pain. So be aware of these symptoms, and if they come, there should be a high suspicion for a heart attack. When the younger woman presents to the emergency room, often there are doubts about the diagnosis of myocardial infarction, and the presentation, even though the patient called in early and presented to the emergency room, the actual diagnosis may be delayed because of the fact that physicians often in the past would think that a younger woman could not have a heart attack and maybe there's something else. And I'll show you some cases of the different types of myocardial infarction when the patient first received a CT scan of the chest, or there have been pregnancy tests done to make sure that that's not ectopic pregnancy, or a different kind of other testing before the actual ECG even was done to confirm that this indeed is acute myocardial infarction. I'm sure some of the survivors in the room might have had similar experiences. And this is why now we know that there are certain clinical features for SCAD that we need to be aware and cognizant of as physicians when we triage patients. Myocardial infarction in young women younger than 50 should raise a clinical suspicion for SCAD. Absence of traditional cardiac risk factors, often very healthy, fit women who don't have previous history of high cholesterol or traditional coronary risk factors. When we do the angiogram, often normal coronaries despite positive troponins and sometimes even typical ECG changes. Peripartum state, we already heard about the high-risk features of SCAD associated with pregnancy. And then history of previous connective tissue disease or fibromuscular dysplasia. I still don't know how to cancel my patients that have these conditions, or how to prevent SCAD. I have some families that come to my office where the mother had a SCAD and then the daughter has one of these conditions. And basically there is a lot that we still need to learn about talking to our patients and making sure that they are aware of the types of symptoms that SCAD could present as a heart attack, and we need to be aware of these. The history of predisposing factors. So when we take the history, often I now ask about emotional triggers. And you will see with the cases I present today, I think that vast majority of cases that I've seen in clinical presentation always had an emotional trigger or lifting something heavy. These are the two things that I've seen, at least in my practice, but also hormonal triggers. I don't know what to say about the coincidence of menstrual imbalances and whatnot and the actual occurrence of SCAD, but we definitely have more to learn about that. SCAD was really something that we're very proud of throughout Canada, and Jackie's hard work to connect us all. And I think that this was very important information, not only because it was one of the biggest cohorts of SCAD patients, but also a cohort coming from Canada. So we could really base our practice on what we learned from Jackie's work and all the other collaborators. As you can see here in the SCAD registry, about 30% of patients who had SCAD presented with ST elevation myocardial infarction. This is the full blockage of the flow to the heart muscle, where the patient needs to go urgently for an angiogram and have the vessel open to reduce the damage to the heart muscle. 70% of patients were with non-ST elevation MI, which is the not complete occlusion of the vessel with still some flow through the arteries, and unstable angina for only 0.4% in this cohort. Chest discomfort was the predominant presenting factor. So this is important, right? We say all women have other symptoms, atypical, neck pain, jaw pain, back pain, but really in 91% of all the patients in the registry there was chest pain. So it's important to remember that if there is chest pain, it may be subsided, there could be other residual symptoms afterwards. Again, it's the most common presenting factor. Most of the patients had elevated troponins, which means some myocardial damage, and about 8% of this cohort presented with life-threatening arrhythmias, whether the trigger tachycardia or fibrillation, which often are associated with sudden cardiac death. So these are two emergencies where patients could collapse and need full resuscitation in a life-threatening situation. Most of the patients had different types of assessment of their ejection fraction, whether through echo or angiogram. And you can see here that about 50% of the patients had assessment at the beginning, with 25 with ejection fraction of less than 50%. The Mayo cohort also describes patients with different presentations between STEMI, non-ST elevation MI, and unstable angina, similar to the breakdown in the Canadian cohort. About almost half of the patients presented with ST elevation MI, and the other half with non-ST elevation MI. So it's kind of almost an equal toss between the two presentations, and a small proportion are unstable angina or chest pain without major damage to the heart muscle. I love this case. I always show it because it's emotional to me. It was one of my first SCAD cases that I did, and it was a young woman who was a marathon runner and very healthy. She was training for marathons, was at the peak of her physical abilities, and was getting ready for a Christmas potluck, and lifted this crock pot that after she carried it around, she felt that there is severe chest pain, but she couldn't believe that this is related to her heart. She didn't think she had a heart attack, and basically made it home, and then at home the pain continued, so she decided to call 911. And this was transmitted through the STEMI phone. There is a subtle ST elevation you can see here in the lateral leads. With that, she actually went downstairs to wait for the paramedics to pick her up, so they don't make the effort to go upstairs to get her. And this is what we had in the cath lab. You can see here multi-vessel SCAD with really reduced flow in one of the vessels here. Spidery looking circumflex artery. At the time, I wasn't sure if this was actually clot or not, because she was taking some medications for heavy menstrual periods, but you could also see the LED was narrowing. So successfully, we were able to open the circumflex artery because of the ST elevation and pain. I had placed stents in the circumflex, which have been serving her well, and she hasn't really had any major symptoms since. And that was approximately about 4.5 years ago. This is a SCAD of a non-ST elevation MI patient who presented with, doesn't want to play, sorry about that, but again, it really depends on the timing of when we take the ECGs, and some of these studies maybe have now evolved into non-studies. Unfortunately, my videos are not playing, so disappointing, but a lot of the times when we do the angiograms, we now shoot the iliacs and the renals to look for FED, and in her case she had multivessel SCAD with her non-ST elevation and was medically managed. This was an interesting case, which these were playing, but they are, sorry, I don't know why.
Sometimes the codecs transited, so it got changed over there, but I think we, I'll just see if I can actually just, yeah, here, it might work just like, just by doing this, it might work.
Yeah. So this lady is super fit, skinny woman who basically loves to ride her Harley Davidson, and then she lifted her bike, she collapsed, and then soon after that, there was an AED that shocked her out of shockable rhythm, and this ECG, which is really not very impressive. So they brought her to the lab. She wasn't intubated. She was quite stable, but obviously had a VT that caused her symptoms. And I started with the family. You can see very small lady with very typical bleeding in the legs, and eventually this horrific looking hematoma in the left main, expanding all the way to the LAD and the circumflex artery, and all the vessels looking very small. So she had extensive SCAD into the left main, and you can see here this little stain and the intramural hematoma. So that was managed medically, conservative management, and she is now 3 years after her event without any angina, without any ischemia. And it was probably one of the scariest cases of left main because it was very high-risk presentation. You can see the hematoma basically extending all the way along the LAD. So she is well, and the only thing she has a restriction for now is not to ride the bike, and she's quite devastated about it, but we managed to go into some other activities that keep her happy. This case just came to me about 4 weeks ago, and this is a 33-year-old registered nurse who was studying for her board exams, and went to do a night shift, and then came home and decided to do some stretching and some jumping jacks just to refresh herself before she goes back into her studies. And as she did a few jumping jacks, nearly collapsed and called an ambulance. And basically upon arrival, she was hypotensive and unresponsive and required full resuscitation. She was not on any hormonal therapy, she's never been pregnant, and basically had this horrific ECG with diffuse ischemia. And you can see here in the left main that there is this very extensive flap into the left main extending into the LAD. To me, it's probably one of the scariest presentations. So she basically was intubated for a couple of days in the ICU. I'll show you the case tomorrow of what happened to her, but she survived this event. And lucky for me, because I'm now very keen to have a SCAD clinic and follow all the patients that are in Manitoba, I got a referral to see her in 4 weeks. And I looked at this angiogram, and the first reaction I had is, I have to send this to Jackie and ask her what to do, because this looks very, very scary to me. The patient was out and about, walking around. I called the patient and I said, please don't do any jumping jacks until you hear back from me. So, presentations vary. They could be from very mild chest pain. There have been patients that would present with chest pain and not ever be investigated until later in life, and then there'd be an angiogram that would suggest a healed SCAD, to dramatic presentations as a sudden cardiac death, as you can see here, cardiogenic shock. It really changes the patient's life, and I'm not sure at what point and how we could intervene to give good advice and help our patients. My thoughts about the presentation is that there's still a lot that we need to learn about the microvascular dysfunction that is associated with SCAD, something that me and Tara and Jackie have been talking about for a while. I see a lot of patients in follow-up after their MI in clinic, and a lot of them, even years after their healed SCAD, they continue to experience some symptoms of angina. The whole paranoia of seeing SCAD that looks scary like that, and how do you follow them up? Do you do an angiogram to make sure this is healed, or do you do something less invasive? Because do I really want to go back and look at this again and touch it, and what am I going to do if I have to deal with it? And then exercise prescription, when it's safe to exercise and whatnot. And these are all not your typical follow-ups that you would do for a routine non-ST elevation or ST elevation MI. So I'm looking forward to learn from you and to talk more about the different presentations and follow-ups. Thank you.